Yeah, so today, my name's Marvin Malek. Today we're discussing approaches to cost control, and we'll try to get through mainstream approaches that are currently being heavily used in the United States. So these are oranges. I love oranges, and let's say that it costs 50 cents each for these oranges, and I buy six. I pay $3 for the six oranges. So what if I want to reduce my spending on oranges? Please name, somebody here, one of you name the two possible ways I could spend less money. Don't be shy. Being wrong means you've spoken, and it's good to speak up so we can get a dialogue going.
You could eat less or fewer oranges, or you could steal oranges.
Okay, so you're proposing a volume strategy to buy fewer oranges. If I buy five, I'll be down to $2.50. So that's useful. It's a volume strategy, fewer oranges, less spending. The other strategy to try to sneak around the system and cheat, we've talked about that in regard to the Medicare Advantage program, ways to cheat to either get more money, get the care, get improve your reimbursement or um, get the product at a lower price. So you could use illicit means. And that certainly happens. There's a lot of prosecution that goes on in this sector of the economy. So that various forms of cheating happen a lot. Yeah, so those are good. One more strategy?
Negotiate and say, if I'm buying six oranges, I'll pay you $2.50 or $2 for them.
Okay, so you're looking for a lower price. So Natalia suggested a lower volume or cheating in some manner, and you're suggesting a lower price. That's exactly right. So you got two primary strategies that are legal. One is lower price, the other is fewer oranges. So it turns out that there is a literature on that. Um, if you want slideshow, let me try to do it. Oh my God, we got to get through these. Sorry, guys. Okay, so how can we save money in interventional cardiology? Coronary angiograms and interventions, stents, stent placement, that kind of thing.
Pay lower prices for equipment.
Lower prices for equipment. So lower price. Is that Therese who said that?
Yeah,
Okay, what do you think of just paying the doctor a little less?
that could work.
Okay, so lower prices per unit. They get paid instead of getting, so the doctor might get, let's say $5,000 to do the procedure rather than 5,500 or something like that. And what you said is very true. There was a tour, the head of UVM, our local tertiary care center where I live, was talking about the fact that he had to pay $1,400 for each angiogram catheter. There's been a controversy about that hospital overspending. So he took some people from the press in and he was showing these catheters and he had looked up how much the hospital pays for those catheters. So I got online and looked up Germany. And it turns out that in Germany, they pay $350 to $400 for those catheters rather than 13 to 1400. So exactly what Therese said is in fact going on in other countries where they actually work on price. And then how else could you save money on interventional cardiology?
Could you invest more in like primary care and preventative measures and like medicine adherence to prevent like further downstream need for these costly procedures?
Exactly. So you could reduce the number of coronary interventions. And I guess you could argue that there's two ways to do that. One is to actually prevent the disease, which is what you're suggesting. And the other is to just say, oh, our doctors are ordering too many. They're not really needed. So criticize the doctors, put them through prior authorization, do something to get them to order fewer. Any number of ways. You could say we're no longer going to pay you beyond a certain number. So same idea, get the price down, get the volume down. So what about deregulation, which is often the strategy from the conservative end of the political spectrum? Would market forces help lower prices? So medical industry prices are generally immune to normal market forces. So for example, in theory and microeconomics, the supplier is able to supply a product like a coronary angiogram for a certain fee. And the person who wants the procedure done constructs demand for the procedure endogenously without being affected by what the supplier wants. So in other words, they're supposed to be independently determined. I want 500 bushels of winter wheat. You're a farmer or a co-op, you're able to supply it. And we use market forces depending on supply and demand. But here, something is going on which is very, very outside the realm of microeconomics, which is called supplier-induced demand. The doctor, the supplier of the service, says to the patient, well, I really think you need a coronary angiogram. Your mom, dad both died at a young age of coronary disease. You're having some symptoms, so you should get this done and I'll do it. So that was the idea that the supplier of the service is also more than affecting demand, is literally creating demand right in front of you. So it seemed like, the normal market forces aren't going to be in play, and the suppliers might have or do have an incentive to create too much volume. So Yuval Reinhardt studied this. He's probably one of the most well-known health economists in the US. He passed away, I think 4 or 5 years ago or something. I don't know which year. Anyway, so he did this analysis, and what he determined was that, let me just go on, 90% of the excessive costs in the US compared to other OECD nations, Europe, Japan, Taiwan, 90% of the excessive costs in the US are due to higher prices in the US rather than a higher volume of services. That was from 2003, a study that he was the leader on. And then in 2019, Gerald Friedman, who had been part of his original team, they redid the study with more recent data and confirmed almost identically that it was about 90% of the excessive spending in the US was not due to volume, but due to prices. So here's Willie Sutton. If you never heard of him, he's a famous bank robber. Here he is in prison garb. And a reporter, a journalist asked him, well, Willie, why do you rob banks? And he said, well, that's where the money is. So with 90% of the excessive costs in the US being due to higher prices than other countries, you would deduce that we should work on lowering prices. In case I forget to say this later, you've already heard about high administrative costs in the US healthcare system. I just want to make clear that when administrative costs are high and the doctors and the hospitals have to do all that administrative work, that leads not to a higher volume, but a higher price, because the person who's contending with those administrative costs in the billing office and the office that interacts with insurance companies, they have to get paid. And the people who are negotiating with all the insurance companies over the rates with their provider relations department. So all of that is administrative costs. And the hospital then, when it bills for the coronary angiogram, they have to build in the cost because the coronary angiogram suite is what's known as a revenue center in a hospital. It generates revenue by doing their procedure, whereas the billing department is not a revenue center. It's a cost center. It costs them money to keep the department operating, and there's no expected revenue. So you're having to generate higher costs in the United States by building in all this administration, and that gets reflected in the price of the service and is neutral to volume. It doesn't affect volume. So what strategy do you think got used in the United States? Were they going to go after prices, or were they going to go after volume? Well, you all know what this answer is going to come out as, so let me just go ahead. So let me go back further than even this slide, but the theory here is that supply-induced demand, the greedy doctors recommending surgeries that are not needed, recommending care of little value, supplier-induced demand, was causing the problem, even though the research had already shown that it wasn't by the Uwe Reinhardt study. So, but there actually was very reputable research showing that it should have worked. And this fellow, who's also passed away, his name is Wenberg. He worked at Dartmouth in New Hampshire. He did a groundbreaking study by doing county by county analyses in Maine and in Vermont of the frequency of various medical procedures. And when he studied appendectomy, taking appendixes out, there was like little variation county to county or state to state. Number of appendectomies per 100,000 people. But when he looked at hernia repair, prostatectomy, hysterectomy, D&C, and surgery for varicose veins, he found tremendous county to county variation, suggesting that surgeons in one county were suggesting more varicose vein operations than in another county, more hysterectomies, D&Cs, and all these operations than in other counties, suggesting that, kind of assuming that the low counties were value care, really good, valuable care, high value care, and the highest counties were low value care. And whether those doctors in those high counties were doing it because they're greedy, or whether they're doing it because of incompetence, they didn't know the standard, or whether actually a lot of their patients, like let's say some woman has vaginal bleeding and has gone through some medical treatments and just, the bleeding's still continuing. She's anemic, whatever, so at a certain point, it's like, okay, we tried everything. Unfortunately, it looks like, hysterectomy is appropriate for you. And in some counties, surgeon might have said, well, let's keep trying other things. And then more and more months go by with all this bleeding happening. And so it didn't really benefit the patient to wait. But, Wenberg's suggestion is that the surgeon who waited was better, was providing higher value care. So there's, lower number representing higher value care. So anyway, this is the conclusion of the policymakers. Get rid of the low value care somehow and try to apply what's called the quality equation, that value equals quality of care over cost. Like how much cost did it take you to deliver really high quality care? Okay, well, that makes a lot of sense. Anybody want to ask about this? Want to digest it for a second? Okay, so how do you measure cost? Well, cost is actually pretty easy to measure. You have money. And so you can measure the number of dollars for one thing. And in some cases, you can measure the number of procedures, and those are easy to count. But the other part of the value equation was quality. And I've kind of alluded to this, but quality is kind of tricky. So and there a famous researcher called Donna Beatty, probably 60 years ago, said, well, you could divide it into three areas. One is structures. Do you have a fire extinguisher in your hospital? Is it working? Is it where it's supposed to be? Is your operating room clean? So the structure that the work is happening in is safe and appropriate. You could look at process measures. What is your process for management of high blood pressure or diabetes? Are you starting out with insulin right away for type 2 diabetes, which would not be correct? So what are your processes? And you can do chart reviews, set standards for your hospital, presumably, taken from national recommendations. And, you tend to look at the stuff that's easy to look at. So, all the patients with a chart with a diagnosis of type 2 diabetes, and how many of them got metformin as their first drug, which is what's supposed to usually be done. Anyway, so you can look at that, but there's a lot of exceptions and it's time consuming. And all you've gotten is how many people are on metformin. It didn't say, are they living longer? So obviously there's outcome measures, quality of life. The patients getting diarrhea from metformin may not be helping their quality of life, even if their blood sugar is a little better. So you could try to look at mortality, but in complications of surgery. But can you think of some problems with those outcome measures? All three of them have problems.
In terms of like charting, every physician charts differently. Like I've seen notes that are pages long and I've seen notes that are 2 bullet points long. So I feel like it would be hard to standardize measures in that sense. And then in terms,
Yeah, exactly. I think that good charting would be more in the second one of process, whereas outcomes is whether the patient's croaked or whether they're still alive. So I think what Therese is getting at is that may not be quite so easy for chart reviews to, like the doctor may well have something in the note that justified whatever it was they did, even though, I didn't give them metformin. Maybe the patient said everybody in my family's diabetes, they all get really bad diarrhea from metformin. I don't really want to start it. I won't take it. So the doctor may not start metformin. It's not the doctor's fault, really. You kind of can't, why prescribe a drug that patient won't take? So you're right. That's all in a good charting note, and the doctor would probably still be faulted, but who's going to sit there looking at every word that somebody writes? Kind of time consuming, hard to use, not completely accurate. So let's go back to the three that I've listed under outcomes. What are some problems there?
You'd have to adjust for pre-existing factors.
Yeah. So let's look at all three, really. If somebody's okay, so there's been an effort to to do what's called bundle knee replacements. In other words, instead of the hospital instead of the insurance company paying a big fee to the surgeon and a big fee to the hospital, the insurance company says, this is what we're going to pay for a knee replacement for a patient between 70 and 75. That's it. This is all the money you get. You can do whatever you want. And then they're going to look at mortality. They're going to look at outcome, quality of life. Did the knee replacement help the person? And was there a complication? Okay, so one potential complication is they went into heart failure after surgery. Okay, well, which patient's more likely to go into heart failure? Somebody who came in with a history of heart failure, who's just in terrible pain on their knee, or somebody who isn't? So now you're saying, well, what if one facility, it's often the academic center, the university hospital, What if they have more complications? Does that mean they're incompetent? Or does it mean that they're avoiding taking patients who are more likely to have a complication and treating them anyway? So complications are a problem. Same thing with mortality. The patient with heart failure is more likely to die, and people with heart failure have lower quality of life than people who don't. So you're going to lose out on all three, even if the academic center did a great job with the knee replacement. So it's exactly right what Tara said. And so this is really difficult. And I'm not going to say a lot more about the measurement of quality because there is a talk on that this Thursday that is a really good talk and is going way beyond, it's exceeding what I just said by an order of magnitude that's worth listening to. It'll really be helpful in putting all that in context. But anyway, one of the issues is preventive care is really easy to measure. Curative care is not easy to measure. Preventive care, did all your patients who are at risk for breast cancer, if you say between ages 50 and 70, did they get mammograms or not? So that's easy to measure. It's yes or no. You can go back 365 days and there you are. But did somebody with heart failure get treated with the large number of drugs that were these days that we're supposed to prescribe? It's up to 6 or 7, and if they have systolic heart failure. So, you got clinical guidelines, but they're problematic. Even the metformin thing, which is a little kind of straightforward, even that has issues that we already discussed. So you can measure these things. Sentinel event is when something really bad happens, like you put in a central line and a patient gets an infection. Yeah, it happens. It's relatively uncommon, and death is a problem because it's usually uncommon also. In addition to the fact that the people who die, usually they had other things going on. So you can start adjusting for risk, and we already talked about that when we talked about Medicare Advantage, that you can game the risk assessment and make your patient look sick. So measuring quality is a big complicated mess, but the insurance companies say all of this incentive to deny care. They're always saying, well, we provide really good care, with data that add up to less than 1% of what doctors are actually doing. So for example, E works in emergency medicine. I would be surprised if there's any way to measure the quality of her care that she would say, yeah, that's a really good measurement. Like, you really captured my performance for this week at work. She tries as hard as she can, and God only knows if somebody could ever assess that fairly. It's just, is she kind to the patient? Is that going to be in an assessment? It's like, it's so difficult to measure quality. And then there's Caldwell's law. When a complex bureaucracy is faced with a high stakes measurement, it will ignore everything else that's not being measured and try to make the high stakes measure look really good. Cheating, fudging, the whole deal. And so this goes on all the time. I've never worked in a hospital where it did not happen. That if any funder says we're going to measure such and such, suddenly everybody's all over it. And we tend to even get rid of other things we might have been working on. So what the insurers use is a proprietary set of criteria to decide on necessity and quality. And if you're not in their criteria, your procedure doesn't get paid, and that your prior authorization is denied, and they can justify it because it's in that set of criteria. So to implement the Wemberg scheme of getting rid of low value care, the US developed HMOs, health maintenance organizations, came about in 1973, signed into law by Nixon. And the idea was you would give a glob of money, an insurer could give a glob of money to an HMO, which theoretically was supposed to be doctors and hospitals in a community, forming an HMO where they would all work together well. They'd use the same medical record, to talk to each other, and they could provide really high quality care. And that was the theory, and it happened. Kaiser in California was the place where it was pushed the furthest, and they did what they said they were going to do. It didn't save very much money. not surprising, but patients, got reasonably good care by any measure they could come up with, and it was able to be financially viable. However, so they were sort of the good guys on the HMO value. Uh, we call that capitation, where Kaiser was given a fixed amount of money to take care of a patient of a certain age. But other people weren't as humane and kind as these doctors were. And these big corporations got into the business within 10 years, and they weren't going to necessarily be so kind and be so accommodating about doing procedures that didn't look exactly right within their proprietary criteria. So that got called managed care rather than HMO, and it's basically an intrusive insurance company. And again, they had these proprietary standards for what they could deny. And there would be prior auth procedures where, exceptions were only granted when doctors had to plead a case. This was especially severely inflicted on mental health providers. It was vicious. It's called behavioral health management or something like that. And companies, for-profit companies, got into the business. The insurance company would pay the behavioral health managed care company fees based on the number of patients that the number of patients they have with a mental health diagnosis, and these companies would get paid more if they denied more care. It was brutal, requiring the mental health providers to do all kinds of documentation and fighting. It was horrible, still is. And so they would often delay and entirely deny payment. So, and prior auth requirements, denials of payment, and efforts to capitate physicians. That means pay the physician a fixed fee. And it got bad publicity because people knew they weren't getting care. Their doctors started telling them. And so there was an article here. I can't tell where this is from. My health insurance company is trying to kill me. So that didn't look good for the insurance company. And then there was a movie called John Q, talking about how, insurance companies refused to pay for a procedure that was, indicated. And so they felt like, I guess we should stop calling it managed care, and we'll be quiet, and we'll maybe be a little less fragrant for a while. So that was the end of managed care. The term went away. But did what was happening went away? That answer is no. It was still happening. Very little change. We just stopped calling it managed care. So around then, which is, say, the beginning of this century, suddenly there was a new concept. It was called value-based care. And so the question, it's a framework for restructuring health systems with the goal of value. Less cost, more quality. And a couple researchers got famous. The guy at Dartmouth, I forget his name, the fellow at Dartmouth got involved. Elliot, I can't remember Elliot's last name. Anyway, so they got all involved and published papers on this is a really good idea. Doctors should come together, and basically they were kind of trying to create the HMO idea that doctors would be really running the show. And unfortunately, it kind of didn't last. The doctors weren't really running the show, and what happened is it got taken over by organizations. Even when the doctors were represented, like we had one in Vermont, it still didn't work. Like the doctor was still, so the way it got implemented in Vermont, and really nationally, this is what's being called for, is instead of paying the doctor for the knee replacement, you give all of the money that you would have paid for the knee replacement to this entity, which could be a group of doctors. That was what these researchers wanted. doctors and hospitals and every specialty in the community, they'd all work together, everything would be copacetic. But it was just as easy for an entity, even a for-profit corporation, to say, well, we're organizing an ACO. And pretty quickly after the proposal was made, there was a lot of lobbying going on, and the insurance companies and other for-profit entities, even private equity, said, well, we want to get involved in this. And they were allowed to. So now you got all kinds of entities getting involved. And a lot of what the methodology in value-based care is not case-by-case denials of an individual procedure, but just simply saying, you doctors in the community, we're taking the money from the insurers, including Medicare, and we're just going to see how your volumes go and what your overall spending is next year. And we're only going to give you 80% of what we got if we're losing money, but we'll give you 110% or 120% if your cost is real, if your volume and the amount of money you're spending is low next year. So it was trying to reverse this incentive. Now, just to back off just for a second, please, someone speak up. I'm going to ask a question. Do you call this a volume strategy or a price strategy?
This one seems a little complicated
Uh-huh.
because it's like it seems like it plays the both, but I guess
Well, make the
the
argument
intent.
for both because you're right, but go ahead,
Okay.
make the argument.
I guess you could argue the intent is to decrease cost by providing the same volume of care for the set amount of patients that they were having, but I'm assuming it ended up decreasing the volume of care because, like you've said, the American health system's so resistant to any sort of cost decrease. So, in effect, I think it would have turned into a volume-based control.
Especially coming out of Wenberg's research on the counties in Vermont and Maine, that it looked like there was a lot of low value procedures. So they were going to get rid of the volume of procedures. And cutting costs was going to be pretty difficult for a group of doctors or even a nationwide private equity company, though in some cases, private equity companies can get some volume discounts on supplies. And they could try to pay their physicians less. So those are possible. But Zach's correct that it's largely been going after volume. Anyway, so this is what they were trying to do. And so this has been the primary approach of the Democratic Party to cost control in general. And they've been putting all their eggs in this basket of primarily volume-based strategy of value-based care, which they call payment reform or pay per value. And I can call it, kind of managed care because you're managing the care by capitating them and you know how they're going to respond if you actually do that. Anyway, so here's this notion of value-based care. And you already know that insurance companies are implementing it in the form of prior authorization and denials, stuff like that, making sure that whatever is done is valuable based on their proprietary criteria. Anyway, so that's one way to implement it. But we're now going to look at what happened in Medicare, because we already know that half of the people who enroll in Medicare have opted into the Medicare Advantage program. So their managed care or value-based effort is going to be done by the the private insurance company they opted in for. And as we said yesterday, that enrollment in Medicare Advantage is increasing largely due to overpayments by the Medicare program. So But that wasn't enough because this notion of value-based care had really, really permeated into health policy discussions and was really dominating. And 15 years later, or 20 years later, it still is. For those of you who've read Hans Christian Andersen, The Emperor's Clothing, or what's it called? The Emperor Has No Clothes. I can't remember, but anyway, there's like, okay, let's see if it works, but that kind of never happened. So let's just take a look at what Medicare did. So here's, I'm gonna move this, hold on. So Medicare got onto the value-based care craze. Let me get through this. Oh, I'm sorry. I'm really sorry. It took me to the beginning, which I didn't expect. Okay, so all right. So traditional Medicare is now at around 47% of people. And what we've already learned is that people who are going to try to stay on traditional Medicare because they don't want your health care managed by a for-profit or other insurance company, which are allowed to deny care when they decide it's not necessary. So those who want to sort of listen to their doctor, talk it over with the doctor, and actually make a decision. Do they need a knee replacement or not, or whatever the decision is? So those people, so there's a motive to want to stay in traditional Medicare, which I share. So I've enrolled in traditional Medicare, and my problem is that I not only have to pay the Medicare B premium, which is over $2,000, about $2,000 a year, but I also have to pay for a supplemental plan because of that 20% co-insurance thing within the Medicare B, which is not good, and you don't want it. It's unlimited, no cap. So, so I'm forced to buy a supplemental plan for Part B, and then I had to buy Part D to get prescription drug coverage. So I'm up to $4,500 a year because that's $2,500 between the two of them, Part B supplemental or Medicare supplemental plus Part D coverage, the drug for prescriptions. Whereas the person going to a Medicare Advantage plan might only pay $400 or $500 a year. In some places, they can actually somehow do it without. They're so overpaid in some zip codes, these Medicare Advantage plans, that they literally charge nothing. Because Medicare's decision about how much to pay them is really complicated, and it's got to do with what zip code you live in. Anyway, so there was traditional Medicare. I was buying a supplemental plan, the features of which are completely regulated by the federal government. They have virtually no latitude. They cannot deny any care. These supplemental insurance companies, they just make money, and so it's kind of easy money. And so the local Blue Cross plans, which could even be small, could provide this coverage, this Medicare supplemental plan, and they didn't really have a competitive disadvantage against the for-profit, the nationwide for-profit insurers like Cigna, Molina, Centene, Aetna, all these national ones. So from the point of view of those companies, the for-profit companies, they felt like, well, after they had kind of tapped out the Medicare Advantage opportunity, they said, well, half the people in Medicare are still in traditional Medicare. Maybe our lobbyists could be effective enough to make some money out of them. Because right now, as things are, we can't compete with the local Blue Cross plans providing supplemental coverage. So what did they do? They jumped on, in Obamacare, there's a little tiny, financially tiny piece of the Obamacare legislation created something called for the Center for Medicare and Medicaid Improvement, CMMI. And they were given $1 billion a year, which is a small change in the Medicare program, and given free rein to try out strategies, and they could continue them so long as they improved quality or reduced cost without hurting quality. So it's basically experimenting, researching cost control strategies. And right at that time was the height of the value-based care trend. So that's what they did. Rather than saying, why are prices so high? Maybe it's because we pay too much for drugs, other coronary angiogram catheters, whatever. No, it never went after price, never did a thing. It didn't reduce administrative costs, which would lead to lower prices if you accomplish that. But instead, it was going to be value-based care, the quality occasion. Is your volume of services too high? Can we reduce it? Get rid of those hernia repair surgeons who repair hernias before they even emerge. So what they ended up doing in the first several years was establishing programs where you would allow doctors in a hospital and a community to come together and form sort of a committee or an entity and incorporate themselves as an entity. Presumably, doctors in a hospital would be a not-for-profit entity, and they would be implementing the plan. And the plan was going to be to give them a certain amount of money each year. And instead of paying doctors, they were going to pay this entity. And as I was telling you earlier, if the doctors in the community and the hospital did too many procedures, they would lose some of the money that they would have been paid. And if they cut the number of procedures, they could get paid an extra bonus for doing fewer procedures. But keep in mind, the doctors are basically still getting paid a fee for their procedure. It's just that a portion of the fee is being withheld if they live in an area with an expensive entity, which were called ACOs, Accountable Care Organizations. So now this gets really complicated because now you have people who still have Medicare paying bills. They still have the supplemental insurer paying bills. And now you're adding in the value-based care entity. So it doesn't take rocket science to figure out what's going to happen to administrative costs. They're going up. So whoever forms the entity is adding cost to the system. And when the doctors in the community have to respond to the entity and meet together and figure out what they're gonna do in terms of, how they're gonna negotiate with the entity, who's gonna capitate them and give them, give them less money if they do too many procedures. What are they gonna do about it? So what if you're an independent surgeon in the community? There's this entity, the independent surgeon is in that community. And what if they just say, I don't want to do this. I don't want to expend administrative effort even reading about the program, much less participating in it. So Medicare never required anyone to participate. And that turned out to be a real Achilles heel in the program, because the AMA has lost a lot of power, but to force doctors to get into value-based care entities was not something most doctors would have wanted to do. And in fact, they never really had to do it because the thing was done by hospitals and regional groups of providers, which would include the surgeons and the primary care people and the hospital. They would all get together, and basically what they said to Medicare is, we're not going to do this if we're going to lose money. We're just not going to do this. So what actually happened in reality right from the start through the Trump administration and through Obama and Biden, what's actually happened is that they just overpaid them, and they allowed cheating when they were going to score patients, and they just paid enough so that doctors wanted to get in. And in fact, we had there was a clinic that had gotten into one of these deals with a private equity funded ACO in the ACO REACH program. And I said, your community is now your traditional Medicare patients in this community are now enrolled in this program, and it's run by private equity. We don't do this in Vermont. And they said, we're in big financial trouble. They were offering all this money for us to get into it. And the reason why the private equity was offering all that money is because they were being overpaid by Medicare. And so it's like so much money to go around and keep doing these demonstrations. Anyway, so in around 2019, okay, so CMMI keeps putting out these programs that are all permutations of the same thing and giving them different names. One of them is called Primary Care First, all kinds of names. They created ACO REACH, ACO Accountable Care Organization, Realizing Equity, Access, and Community Health. That's what the REACH stands for. Bunch of words. It was a rebranded form of a prior program with an equally imponderable name, Direct Contracting Entity, that Trump had created. So Biden took over, and all the people who were like single payer supporters were saying, get rid of this program. It's increasing administrative costs. You have no evidence that it's saving money. Scrap it. Do something useful, or at least get rid of it. If you can't do something useful, do nothing. But no, Biden appointed Liz Fowler, who had been previously worked for both the pharmaceutical industry and the insurance industry. And she declared that 100% of Medicare enrollees, whether they're in a Medicare Advantage plan or whether they're in traditional Medicare, they were going to be in an accountability relationship by 2030. So in traditional Medicare, used to be that you'd pay the doctor. That's simple. The doctor and patient would talk it over and there would be a decision. But CMMI was going to insert this entity. And the entity could be a bunch of doctors in the community. And in some areas, it is all the hospitals and doctors in the community. But in others, it's a private equity run firm. And so to be an accountability relationship, according to Liz Fowler, who's depicted here, a Medicare Advantage plan was fine because they were going to pick at the doctor, the greedy doctor, but you were going to be forced to participate in an ACO or some other disincentive scheme within traditional Medicare because they had all these different names, as I said. So the entity would engage most of the protagonists, the tertiary care center, primary care center, the doctors. And they could be small provider models, big provider models, and corporate run. And when Trump took over, they even allowed corporate run ACOs and private equity, usually for profit. And you can imagine that it's hard to outcompete a company that's with the financing and savvy of United Healthcare or a private equity firm. So they rebranded one of their old programs. There were dozens of programs, and they're all basically the same. But here is one a common model. For each primary care provider who has signed a contract to get into this, they quote, align each of that primary care provider's traditional Medicare patients into that entity. So let's say it's a private equity company that the primary care doctor is signing up with. Medicare will go through an analysis of which primary care doctor in the community has seen this doctor's patients at that time the most. And not who's seen the patient the most recently, but they look through the past 2 years of the beneficiary's claims to figure out which primary care provider saw the patient the most. Think about that. So what if you were going to a doctor in 2024, you went 3 times and you finally got fed up. I can't stand that doctor. So finally you got on a list and you got to see a different doctor who you're happier with from the visit. But it's 3-1. So you're going to get aligned to the previous doctor because you saw that doctor more times. So this is what's going on. Patients are not involved in signing up. So the way the plan would grow is by contracting with more primary care doctors who have a lot of traditional Medicare patients. So there's no advertising to patients. To the contrary, patients are, quote, informed with a deceptive handout that is so horrendous that I can't even tell you how offensive it is. It doesn't say in the handout that this entity is going to withhold a lot of money from the doctor instead of letting them get paid and decide at the end of the year whether they're going to pay the doctor and how much. None of that is in the handout. All it says, this is from Medicare, not from any of these private entities. Medicare is a standard handout. Okay, what it says is nothing about the finances. It says your doctor is now in a organized effort, coordinating better. This is the big word. Working on improved coordination of care. How a private equity funded company in New York City is going to help that doctor coordinate care is beyond the ken of any human being, but that's what the handout says. They're going to work harder on coordinating care so that you get only the best possible care that you need. And no consent involved, the patient's just in. And the only way to opt out is by finding a new primary care physician. You can't opt out of the private equity company. You have to get rid of your doctor who already signed up with it. Or try to persuade your doctor not to stay in it next year. So there's 3 ways these companies were able to generate profit, maximize the number of enrollees. We already talked about that. By the entity could sign on get more primary care doctors to sign in, maximize the revenue per patient, or minimize expenditures. So alignment, linking with more primary care doctors is the strategy that's going to go on here. And no Joe Namath anymore appealing to patients because you're just looking for primary care doctors who are willing to sign on. And the motive a primary care doctor is going to have to sign on, if the amount of money they think they can rely on is greater than whatever risk is involved. And so the overpayment was pretty great. So these entities could make a pretty good offer to the primary care doctors. Nonetheless, Medicare has kind of 2 types of plans of these ACO type plans. One was where you only got paid extra if you had less care going on. And the other one was where the doctor actually lost money if their patients cost a lot. And doctors were very reluctant to get into those deals, even though they're actually more effective at reducing costs. But very few doctors wanted that, and that's still the case. And the current version of Trump is now saying that we're going to get rid of any plan that doesn't have both upside risk and downside risk where the doctors could lose money. So it'll be kind of interesting how this program devolves. But so far, the Medicare payment to this whole deal has been generous, and so it hasn't been a problem. And just like in Medicare Advantage, each patient is coded separately, and so you make your patient sound sicker, you get more money out of Medicare. And these private equity companies and for-profit companies are really good at coding you know, in the best possible way so that they could get a whole lot of money out of Medicare. So they could probably even make this particular patient look really sick, even though she doesn't look it. Anyway, so that was the risk scores are going to drive reimbursement, just like in Medicare Advantage. I'm not going to go through the case, but this is basically a case where, or maybe I will go through it. So here's a case where somebody had a risk score of 1.03 because they had heart failure and diabetes and depression, which they called major depression. So, and asthma. So this is, I mean, E and I have both seen tons of patients who have all this stuff going on. So this is familiar ground. So they get that entity gets $9,000. But if they're clever, they can get obesity and somehow call it morbid obesity. That's a little harder to fudge because that has a definition that's a little numeric. That'll be hard. But you can just point out that there's just a little retinopathy going on because one report said maybe the patient has retinopathy. So that takes it up a good deal. And then single episode of mild major depression. I don't even know what that is. I'm not in the field of mental health. If it's major depression, how could it be mild? Anyway, that's in there, and that got them 0.395 on the coding scale that they're using. Heart failure, they couldn't seem to do more with, but asthma got relabeled as COPD. It's often a little hard to distinguish the two. In theory, it is, but in practice, it's not so easy. And then the ulcer, instead of just being a little sore on their leg, oh, now it's a stage 3 cutaneous ulcer. And so that got them 1.2. That was a real find. And then when you have three big health problems, there's like an interaction code that got added on, which was, I don't know how they score that, 0.14 and 0.19. The concept is, though, that the same patient got them up to $32,000 just by coding in a clever manner. So you can imagine what this does to administrative spending in a doctor's office. There's now going to be all kinds of hounding to go on to get them to code in the best possible way. AI is now used on both sides to code it and then to deny it. And so this is like a battle of new AIs fighting each other. And the doctors are not exempt. They still have to do things to help their AI along. But this is what goes on in this country. So some of the issues with the model is that you've got a middleman between Medicare and the providers. If they deliver less care, they get higher profits. I'm paying $4,500 a year, and I didn't ask for this. And frankly, I am angry about this. This really makes me angry, and it didn't matter who I voted for. Either political party was going with this program. I'm not happy about that. They are allowing private equity investors, which we even have in Vermont, supposed to be a liberal state, and as well as commercial insurers. And the entities were allowed to keep 25% as profit and overhead, especially if they can cut costs. And their coding allows them to get more income. So they are often able to retain some money. And then it's both complex administratively for everybody and financially risky for doctors. And there is a conflict of interest for doctors. If a patient knows that their doctor's getting paid less, if they say, yeah, you do need a hip replacement, then you could worry about that. Maybe the doctor said I shouldn't get it because I have heart failure. Maybe he's exaggerating. I have heart failure, but I take medicine for that. It's been doing really well. Maybe he's doing that because he wants to make more money. So the problem is if patients learn about this, they're probably not going to be happy. And so here's the flows of money. So this is complicated. So Medicare is giving money to the ACO REACH, not to the doctor. And if, let's say that they do really badly controlling the amount of spending, then the ACO REACH has to give money back to Medicare at the end of the year. Then, starting with the REACH entity, they're giving money to the doctor, including the regular payment. And if the doctor really economizes and doesn't order much much procedures, then they get a bonus. But if the doctor's patients turn out to be pretty sick that year, the doctor has to give money back, which their health center, wherever they work, they may not have that in the budget. So this is very problematic for particularly for doctors who work in poor communities and for community health centers, because those people are a lot sicker. And the other thing, in the ACO REACH in particular, Biden was giving extra money to practices that have a lot of minority patients. And guess how that's going to go now that when the Trump team figures that out. So this is very problematic, especially to the doctors who treat the sickest patients, and those are community health centers. So that final thing about this, okay, so Medicare did a study. I'm sorry, take that back. Medicare has done studies, and they're all minor. They're exploring little aspects. This program seemed to save a few bucks. But finally, the Congressional Budget Office did an analysis of the overall impact of these dozens of programs that CMMI was spinning out, all of them similar to each other, value-based care programs, going after volume, never price. And what did they conclude? The CBO currently estimates that their activities increased direct spending by $5.4 billion, which is a teeny fraction. So essentially, $5.4 billion in Medicare language is nothing. So we'll say there was no effect. Be over 10 years. And nothing's changed since then. So this study came out from the Congressional Budget Office, and it was as if it never happened. This is a major study, September 2023. So we just go on with our value-based care, and we're in these schemes and we're out of these schemes, and the schemes change. Some of them are more transparently really bad for Medicare financially. And so so the CMMI scraps a lot of programs along the way, but then they spin out new ones. And Liz Fowler and her gang over there, she may have already been replaced. Whoever replaces her will do the same thing. And they'll spin out more programs and get rid of others. And, we'll be in the same conundrum. So, here you are for patients. They can't choose whether to participate. They may never even find out about it. They have to find a new doctor if they want to get out. And they're paying $4,500 a year to get this. And it's doing a lot of the same things that Medicare Advantage plans do. Now, for me, I have an advantage over all the other patients who are being shoved into these things. I'm a doctor. And so I can, if I know a procedure is needed, like a hip replacement, I'm probably on friendly personal terms with whoever's going to treat me. So even though they may have an incentive for me to get less care, I'm not the person who's likely to suffer. I'm going to do better in this because what this program does is it dumps the incentive onto the doctors. Whereas in Medicare Advantage, the insurance company, if I were in a Medicare Advantage plan, they don't care that I'm a doctor. If they feel like denying something, they're just going to do it. So, yeah, I'm safer, but the other patients are facing doctors who have what can be an important financial disincentive. And if they stop overpaying everybody in the program, then that could get pretty serious. So this is value-based care implemented by Medicare. And in the private sector, nobody's gone further with it than Medicare because it's unpopular, complicated. Doctors are not asking for this, nor are hospitals, unless they can make more money and they're overpaid. And it's only Medicare who's overpaying them. So anyway, so that's kind of the DCE program. So let's leave a little time for questions for that one. And I'm really sorry that I'm injecting emotion into this, but I'm sorry, this is very frustrating.
First, I want to say thank you for injecting emotion into it because it's personal, it involves people, and I think it's refreshing. So thank you for doing that. I also,
I'm
Ariana,
not lacking.
Ariana posted a question in the chat. She was asking, how do they decide the degree to which they increase the score in risk reimbursements? Like how it went from 0.45 to 1 point, whatever it was. Correct me if I'm wrong, Ariana.
I'll answer that question, and then if Ariana wants to ask something different, she'll have a chance. So here's how it works. The decision of what score you're going to give for each individual patient is determined by the entity, whether it's a Medicare Advantage plan over in that program, or whether it's one of these ACO REACH or, entities in the value-based care programs. They score everybody. They do it in the most lucrative way they can. And then Medicare has the power to audit them. Now, there was an inspector general who did those audits, and I don't know what percentage of the auditors and the inspector generals were laid off by the Trump administration, but it happened early in his term and it was not small. So I don't know how many are left in the Medicare program to even do these audits. But what I can say is for the Medicare Advantage program, they were auditing every year, once a year, and they would take a sampling of patients from each Medicare Advantage plan and analyze their coding and look at their expected utilization based on a lot of factors, what their hospitalization rate was, what, kind of complicated. There was a complicated modality that they would they could look at the subsequent year sometimes in the preceding year and see how much utilization they had. So in other words, say look at the preceding year. You do an audit of a patient gets into a Medicare Advantage plan when they're 65. And Medicare may have access to how many hospitalizations they had when they were 61, 2, 3, and 4. And if suddenly all of their Medicare Advantage patients seem to be scoring much higher than those patients were scored back when the doctors coded them before they were in Medicare Advantage, that starts to look really suspicious. So if all their patients are suddenly becoming more complex at the same time, namely the moment they enroll in one of these schemes, Medicare Advantage plan or these other value-based care schemes, it starts to look suspicious. So they can start doing estimates of how much the overpayment is. So it's basically auditing by an inspector general in the Department of Health and Human Services, who is paid independently of CMMI and independently of the entity or the Medicare Advantage plan. And those audits are available. And I already told you, I think that after 2 years in office of doing nothing, Biden did absolutely nothing about overpayments in Medicare Advantage. Suddenly in January 2023, they pulled out all the audits, including the recent one, and they said, we've been overpaying you every year since 2007. This is not okay. If they do an audit of these entities, they're going to find the same thing over in the traditional Medicare side. This is a MO. This is the way things go. Modus operandi of the industry. So the question is Medicare going to do the audits now that they have lost a lot of inspector generals? And even if they do them, what happened after January 2023? Big lobbying storm and, from the Medicare Advantage companies, the private insurance sector, and they backed off largely. They did a little bit, few things, not much. So, this is, when I look at this struggle, to me, it's going to take big change. Like people say, oh, you shouldn't be a single payer reform supporter because that's non-incremental change. That'll be really hard to implement. I don't know. I just think as long as, the lobbyists are going to kind of rule the healthcare system, regardless of what entity, of which programs you're talking about, I don't think it's going to change much. So I'm not a big believer in non-incremental change. We'll talk more about that later in the internship, but anyway. I got off track on that question, but anyway, sorry.
I have a question about how I know you referred to like patients being manually assigned to the provider they saw the most in the past 2 years to be their PCP. Is
Automatically, yeah.
automatically, or sorry, not manually. Um, so it was just like one day everyone was assigned to this and they didn't really know what was happening, and then since then have people left, or is this are people even
Wait,
aware
wait,
this is a
define the word people.
or the patients, sorry, the patients. Are patients even aware that this ACO has to reach is like a program and that their physicians seemingly could be disincentivized to provide them with care they need? Or is everyone just like it's work, it doesn't even impact them in a way that they can like tangibly feel? I'm confused about because it seems like this is just like private insurance managing care from what you're saying on in a different repackaged method with the like more of the impetus on providers to do it instead of like an insurance company physically saying we're not going to approve this. Like,
Hold on, let me stop you for 1 second.
Yeah.
That's exactly correct, and I hope everybody understands what he's saying. It's exactly right. They're dumping the incentive stuff directly onto the doctors rather than picking at it themselves with prior authorization. That's what you're saying, right?
yeah, but you said
Okay, go ahead.
you can leave the doctor once they join this plan. Are people doing that, or are I'm just I'm kind of confused why someone would want to stay on a physician enrolled in this program.
Okay, let's get at all your questions. You had at least two and maybe three.
Yeah.
So the first one, are patients informed that they're on this? And as I told you earlier, I had a slide that had that information sheet, but I'm trying to decrease the number of slides anyway, whatever. So the information sheet says, oh, your doctor is signed on to a special program in Medicare that will help to better coordinate your care and provide you with only the highest value care. So we just thought we'd let you know. And if you have any questions, then call some line that's never going to have a human being at the other end, or you ask your doctor about it or something. So that's the information sheet. So I would bet when you get into the clinic and start treating your first Medicare patient who's not in a Medicare Advantage plan, you could ask, but you'd have to find out first if the hospital that you're in is actually in one of those schemes. You could do this without getting yourself in trouble. Let's say that the company is called, Abacus. One of them is called Abacus or whatever that is. I think that's their name. And you could just say to them, have you heard of Abacus? Do you know anything about it, or, about the contract with your provider? And just, if they say, no, I haven't heard of it, just leave the topic at there. And because that may seem like an odd thing for you to ask a patient. The patient may want to know why you asked the question. But when you're treating a patient, you can almost always leave the topic that's extraneous to their care and focus directly on whether they're having chest pain and what it's like. Put your focus right back on them, and you spent like 2 seconds getting the information you wanted, and then you're back doing your job, focusing on the patient. So you can get away with little things that don't take too long and that you don't emphasize, and the patient didn't remember it. The patient says, why do you ask? He says, oh, nothing, I just wondered. And then just go ahead. How's your chest pain? What's it like? So you can get little bits of information if you're like an investigator, curious. I didn't answer all your questions. What did I miss?
I was kind of rambling as well. It was just, yeah, it was mainly like, why would someone go on a plan, like voluntarily choose a provider on this plan when there is the perceived,
Okay, so why don't they just change primary care doctors?
yeah,
You know the answer to that question? Do you know
the-
how hard it is to find a primary care doctor? And I mean, in rural, you can just forget it because all the care in the community that's convenient is going to be one provider. And that's the situation everywhere in Vermont and probably in all the rural areas of the country where there's basically one doctor for your community. But even in an urban area, it's not so easy. You know, they have long waiting lists. Nobody wants to go into primary care because that means they're going to work every evening of their lives. And so, you know, it's kind of a relative shortage, and you work every evening, and in return for that, you get the least pay of all the specialties. So it's hard to find a primary care doctor. People go into that field out of the goodness of their heart, and, you know, they're willing to do that, their future. So I don't mean to discourage you, but you're having a lot of speakers who are telling you, oh, go into primary care. And it's fine. You're doing a lot of good for the society if you do. But it's hard to find doctors. In most developed countries, about half the physician workforce is primary care, or, you know, primary care, mental health, pediatrics, one of those fields. And the other half are specialists. In the US, it's 80-20 specialists to primary care. So it's tough to find a primary care provider. And, you know, and that means that a lot of people use the ER for their primary, you know, for basic things that could have gone to, in a normal country, would have gone to their primary care provider maybe the next day or something like that. Any other questions?
I just did a quick Google search and it seems like the AMA is in favor of ACOs and value-based care. And neither like pretty left-leaning Democrats, like for example, Sanders or Warren, they haven't spoken about this topic. So I was like wondering if there's any, I guess like any larger dialogue about this issue, and are there any current policy efforts or any other efforts to keep this in check?
Yeah, so in terms of the AMA, one of the students who you're going to talk to later this week worked on the AMA in her state medical society, and I'll let her report on how that went. But I can tell you that as long as this is voluntary and that doctors are not forced into them, and they're not forced to get into to a scheme where they could lose money, then the overpayments look good to the AMA. And furthermore, I already told you there's like dozens and dozens of these programs. So if any of them are getting serious and jeopardizing physician pay, the AMA will, you know, not support that program. But as long as there are options where all the providers are being overpaid, I don't see the AMA coming out against it. Also, value-based care is the trendy word. You know, the fact that it doesn't mean, you know, much different from what's been going on for 53 years with this using administrative complex entities to get doctors to lower their volume of care, right from the HMOs in 1973. So, you know, there's continuity here. We keep rebranding them, whether you call them HMOs, you know, managed care, an intrusive insurance company, or Medicare Advantage plan. It's all sort of the same concept. You're introducing an entity to come between the doctor and the patient, or to, in this case, to influence the doctor. And, you know, it's to reduce volume of care, basically. So that, you know, the AMA still hasn't embraced, they still haven't said that they don't oppose single payer healthcare, I think. Your guest on Thursday, she actually may know that better than me, because that was one of their struggles. They were going to try to get the AMA to at least say they didn't oppose it. And then the step after that would be to say for the AMA to say they actually support single payer healthcare. But until they're going to do that, then they're going to have to go with what's trendy and try to make the federal people who are in power and CMS, they got to make them happy. And just to give you a sense of the AMA, they did not oppose Robert F. Kennedy's nomination. ever, not a single word. So the AMAs, they have progressive positions on a lot of things. And I think I emailed you guys an example of one of them. And there's a lot: adolescent health care, access to abortion. The AMA is progressive on many policies, but at the top of their list of priorities is doctor pay. And this, they're more worried about single payer healthcare than they are about this kind of nonsense. And they've been getting overpaid so far for it. So it's a real problem. I didn't answer all your questions. So I answered the part about the AMA, and you're going to hear more about that from Katerina on Thursday. But what was there more to your question?
I guess
Sure.
just like, are there any other like organizations or people speaking out about or policy bills that are
Yeah.
addressing this issue?
Well, I'm sure National Nurses United, PNHP and National Nurses United is on the list. There's senior organizations, not AARP, because they're totally in bed with the insurance industry, but like um something called Cove of Vermont Elders, uh Coalition of Vermont Elders or something in Vermont, and that's part of a national organization, and they oppose all these schemes. So there's a limited number. This really hasn't gotten publicized. It's at least Medicare Advantage is out there, and it's taken us years to get Medicare Advantage out there as something you could question. And nonetheless, despite, years of working on that, still people are willing to sign up. Admittedly, the financial incentives to go into a Medicare Advantage plan are quite large. So, 400 a year versus 2,500 is a pretty meaningful incentive. And that statement was not accurate. Okay. The entry cost is $2,500 a year for me. And the entry cost into Medicare Advantage, but Medicare Advantage can keep charging co-pays till they get to $9,000, $9,300. And I don't have co-pays at all, or co-insurance at all, I should say. So I bought myself into really high quality insurance and paid a price. And the Medicare Advantage people did the opposite. They took a cheap entry and are hoping they're going to stay healthy.